Hello, welcome to Lecture 2 of our four-part series. Today we're going to cover writing a narrative and using the chart method. Really, my main goals during this lecture is to give you guys the tools to, whether if you've never written a narrative before or never done patient documentation, or whether you're very experienced in that, but maybe need a few more skills organizing your thoughts or including vital information, pertinent information, and excluding those that are not important. So we want to try to cover a lot of bases during this lecture, but I've also tried to boil it down and make it as simple as possible. So first we're going to start off with just writing a basic narrative. A narrative is the portion of your documentation that you write basically telling a story about what happened. It's a portion of your PCR, typically at the end of it, and it is exactly what you would imagine by the name of it. It is a narrative of the story of your patient care, your patient transport, your patient history, all of that included in a short story, if you will. So to cover the narrative, we have right here, right up front. This is not something that you really need to be afraid of. I know a lot of students, as they begin in their career, whether it be during their clinicals, and then even paramedics or other licensings, like basics, advanced, when they graduate, sometimes they feel afraid to write narratives because they feel they don't really know where to start. So today, that's what our goal is to get rid of that fear, get you guys some practical tools on how to include really important information, keep it concise, give you some tools to organize it. So that way, whenever you get out in the field, once you start doing your FISDAP reports, all of your online reports, you don't really have any fear about it. We can get in there, get you used to writing these reports, get some practice in there. So once you graduate, you're able to give professional level documentation and write a really good narrative that can both be beneficial to your patient and beneficial even to yourself. Like I said, your narrative is not something that you have to be afraid of, really. I view it as your time to show off your patient care. This is where, whether you were rushed in your verbal report, this is where you get to show, and this record that's going to follow with you, that you are a high-quality healthcare professional and that you know exactly what you're doing. When you write your narrative, you get to show that you did your assessment, that you did all the treatments correctly. It stands for what you were able to do. I have seen great paramedics that can give good quality care but cannot write a narrative. So if you read their narrative, it's not really giving a proper representation of them because in their narrative, because they didn't have the proper skills, it may appear that they weren't able to give the quality care that they were actually able to. But that's also vice versa. If you're not able to do the proper stuff, but you know how to write a proper narrative, of course, that doesn't make up for your care. Your patient care is number one. But if you're able to write a proper narrative, it's going to highlight those good qualities that you have. Your goal, really, when writing a narrative is to paint a picture with your words. You want to try to take the ER doctor and put him right there on scene with you. You want him to be able to experience the same things that you experienced when you got out of the vehicle. So that way he can know, one, how crucial the patient is or isn't, so that he can see the patient right there whenever you got him prior to any treatment that you may have given him. If you have a patient who's having an asthma attack, and you treat that while you're en route, and by the time you bring them into the ER, the patient's beginning to have some relief. If that's all the doctor sees, if you gave no report, left the patient there, it's going to be hard for them to imagine how the patient may have been looking prior to your treatment. So putting the receiving staff right there in your shoes is really important. You try to think of what caught your attention and what details are important and really what aren't. You want to be sure to describe the mechanism of injury or the nature of illness and all of the events that led up to what happened. That's where documenting and getting a good patient history is very crucial. So a few things, kind of general, but that should be included in your narrative, are your surroundings, your initial impression, the patient's condition, your assessment findings, what maybe what the patient said or didn't say. We covered in the last lecture how to document that. You want to remember, if it's a direct quote, it goes in quotation marks, and if it's a fact that the patient stated but not in their specific words, you want to make sure that you're clear on who said them, whether it be the patient or a bystander, and make sure that you're able to translate that fact properly if it's not in their exact words. You also want to document any changes that may have happened in the patient's condition and any other details that you feel are very crucial to that patient's care. A few things that you need to exclude while you're writing a narrative is really, first off, your feelings. We go to a wide variety of calls, and you may have certain opinions about different calls. However, there's no place in EMS documentation for your opinions, your feelings, or any suspicions that you have. You never want to state your suspicions. You can insert the facts that led you to that suspicion, but you never want to state your suspicions directly. You never want to say things like, that patient appeared to be drunk, or I think the father hit her with a bat, things like that. But you can include statements, instead of saying the patient appeared to be drunk, well, what made them appear to be drunk? What made you think that the father was abusive? So document the details that led you to that. So you may say, instead of saying the patient appeared to be drunk, you may say things like, there was a notable smell of alcohol in the car. The patient had slurred speech, a staggered gait. There were open alcohol containers in the car. You could say the patient stated, "I'm sorry, I had too much to drink tonight. I really shouldn't be driving," end quote. Those are all appropriate ways of leading to a suspicion that you may have gotten. But you never want to just state your suspicion. You always want to give examples and lead them down that same path. You also want to exclude any non-essential information. You want to keep the patient's medical history and any history really pertinent to their chief complaint, or that might be considered roughly pertinent to their chief complaint. If they're having chest pain, the fact that they have diabetes might not necessarily be related. It can be, but that's important enough to include in your documentation. Now, if they broke their arm when they were 4 and now they're complaining of shortness of breath, and they're 35, that doesn't really need to make it into the narrative. That's just going to start clogging up your report. And you also want to avoid wordy statements. In your narrative, you want to record any treatment and the patient's response to that treatment. You don't want to just say that you place the patient on oxygen. You also want to say, why you place them on oxygen in the first place, the fact that you did it, what time, at what route, what dose, all of that information. And then you also want to state how they responded to it. So if they got better, you want to give those clear details, saying patient's respirations came down to this, altered mental status went away, whatever happened to change. Pulse ox went from 92 up to 98 or something like that. You always want to include those details. If you kind of get stuck in a rut, you can ask yourself a few questions. You always want to answer who, what, when, where, and why. If those details aren't in there, then maybe that's something that you can do. And you always want to include any extenuating circumstances. These can vary from call to call. We have a few examples here: extrication, any traffic detours. If traffic was really backed up, then that needs to make it in your narrative. So when they're looking at it and they see, hey, this should have only been a 20-minute transport, but it took you 45 minutes. What happened? You want to have that already documented so it doesn't look like you're trying to cover your bases once you are asked about any of the information. If it helps you, you can use mnemonics, things such as sample, OPQ-RST, or even AVPU. If it can help you follow a pattern in your assessment, it can help you follow a pattern in your documentation. Up next, we're going to talk a little bit about the chart format, or the chart method. The chart method is one of the most common formats in writing your narrative. It really helps you to, one, find a pattern in your PCRs from one PCR to another, and it also helps you remember everything as you're going through your narrative. So as you get to a certain point, if you tend to kind of lose your ground, you can refer back to the chart method to help you find your footing. The chart method still follows a general chronological order. However, in my opinion, it adds a little bit more clarity and organization than a strict timeline type narrative. If you look at the way a general call goes, you move from multiple forms of assessments and your treatment is sporadic depending on what you find and its severity. However, when you document, we're using a chart method versus a timeline type method, all of your information that's related is really grouped together. So though you may interview the patient all throughout your transport and throughout your treatment, you may find out little details here and there about their patient history. You may find different things in assessments and then treat them immediately, depending on how severe they are. The chart method really helps you to organize all of that information into specific areas. So whoever it is that's reading your narrative can come back and pinpoint specific areas and find out that specific information. So we're going to break this chart method down a little bit, take a look at what all of it stands for, and look at some examples as well. So the chart method, before we start, of course it's a mnemonic. The chart stands for C stands for chief complaint, H stands for history, A stands for assessment, R stands for RX or treatment, and T stands for transport. So we're going to start off by looking at the C portion, or the chief complaint portion. The chief complaint is really what the patient, the family member, or even the caregiver tells you is wrong with him or her. And of course, if for whatever reason your patient is unresponsive or is unable to give you their chief complaint, your chief complaint reverts back to what you were dispatched out as. In this portion, what I like to do is start off by talking about how I was dispatched to the patient. So I'll note whether I was dispatched out as emergency or non-emergency, so using lights and sirens or not using lights and sirens. I give a little bit about their chief complaint, some basic information about the patient, and then I input my general impression right there in the C portion. So in my opinion, the C portion is really your introduction into your narrative. It tells whoever's reading your narrative all of the basic information that they need to know to get an introduction into that patient. They know their age, what they're complaining of, and really how you found them prior to any treatment or any kind of assessment. So we'll take a look at an example here. An example might be dispatched emergency to a 55-year-old male complaining of, quote, a tight feeling in his chest. The patient was found sitting upright in apparent distress, alert and oriented ×4. The patient was diaphoretic, pale, and clenching his chest. So we can see how that's broken down here. We're dispatched emergency, that gives our dispatch information, a little bit information about the patient, 55-year-old male, his chief complaint, a quote, tight feeling in his chest, and then gives you a little bit information about my general impression. He was alert and oriented ×4, some of what I saw as I looked at the patient. So that basically wraps up the C portion, the chief complaint portion, or you could look at it as your introduction. Next is H. H stands for history. And I break the history portion down into really two different forms of history. I look at the history of the present illness, really what led up to what's going on right now, and then any other past medical history, things that may be important for you and future caregivers to know about. During the history portion, you really want to utilize and include mnemonics like we spoke about earlier, things such as sample and OPQRST, if those things help you to include all that information. Just as you go through your assessment, these things are helpful to keep you from forgetting a step or forgetting to ask about some specific information. If you use these in your narratives, just like the chart format, they can help point you in the right direction. Now in the history portion, you also want to include any statements that the patient made about the current event or any past pertinent events. That would be part of the history of the present illness. Now in my history, I include, of course, the history of the present illness, any past medical history, but also include any medications that the patient might be on, and of course any drug allergies that they may have. So we're going to look at an example here. Here we have H for history. The patient stated he was sitting in the kitchen table 15 minutes prior to EMS arrival when the pain began. The pain radiated to his back and to his neck. The patient reported nausea and vomiting post-onset. So right there, before we go on, we have our history of our present illness. We know what was happening that led to this current chief complaint of, quote, tightness in his chest. And then we move into his past medical history. He's got a history of diabetes type 1, hypertension, erectile dysfunction. He's been a smoker for the past 30 years. He had a heart attack or an MI 6 months ago. And then we look at his medications. He's taking Viagra, atenolol, insulin. He takes a baby aspirin. And then we see that he has no known drug allergies. So we see how this is broken up into different forms of history, but all of this information, we may gather this at different points during our actual call or during our assessment and treatment of the patient. However, we've grouped all this information into one specific area, so whoever's reading it can read this little portion, this little paragraph, and see all of the information about their history that they would need to know. So we started off with C. C stands for chief complaint. H was for history. A stands for assessment. In your assessment portion, you want to include any information about any assessment that was done by others, maybe prior to your arrival. So if you get on scene and a first responder has already taken down the patient's chief complaint, perhaps asked them about their medications, or has obtained a set of vital signs, you need to make sure that that information is included in your narrative, even though you may not have been the one to do it. You also want to include, say, if you are paired with another ALS unit or another unit that is doing care that you're not necessarily working for, say you and then you're paired with a fire department, you want to include any of the information or any of the assessment that they did, as well as their treatment, of course. In the assessment portion, you want to include your primary survey and also your secondary survey and your ongoing assessment. You want to include information about their airway, breathing, circulation, any kind of determining transport, just like you would go through on perhaps a National Registry check sheet. You want to include things such as DCAT, BTLS, and OPQRST in this portion. You also want to make sure that you include pertinent negatives. Now, what are pertinent negatives? Pertinent negatives are things that were important giving the current situation or the current medical problem that needed to be checked but weren't present in this specific patient's case. For instance, if you have a patient with altered mental status, there are a number of things that you need to check. So if you check the patient's blood glucose level and it's within normal limits, you need to note that you, one, check that and the fact that it was negative, so that way they can see that that was not a cause of the patient's chief complaint or present symptoms. You also want to include any information obtained through an EKG, a pulse ox, blood glucose, all of that information. If it's able to give you some kind of printout, such as in an EKG, you want to make sure that you, however your current form of documentation allows you, you want to make sure that you attach that to that documentation. So to look at an example of the assessment portion, something may read such as, assessment revealed the patient to be tachycardic and mildly hypotensive. As the assessment progressed, the patient began to develop shortness of breath and altered mental status. Breath sounds were clear bilaterally, vital signs were blood pressure 96/56, heart rate 124 and irregular and thready at the radial, respirations 24 and labored. SpO2 was 89% on room air, and ECG revealed, of course you would insert that if you're able to interpret ECGs. The patient was treated for a suspected MI. So right here we have a few things that I'd like to point out. Of course, the breath sounds being clear bilaterally is a pertinent negative, because if the patient is developing shortness of breath, you want to see what is causing that. And this right here lets you know that there are a number of pulmonary issues that could have arisen, but by noting that they were clear bilaterally, you're ruling out a lot of those. The second thing that I'd like to look at is where right here at the end it says the patient was treated for suspected MI. This is called your field diagnosis. Now, of course, we're unable to give a specific diagnosis or a permanent diagnosis because we lack a lot of the tools that may be needed in order to properly diagnose this. However, including a field diagnosis in your narrative and in your report really helps to point the reader in the right direction. It's saying, through my assessment, this is what I suspected was going on, and this is the direction that my treatment then followed after my assessment. So we've got C, chief complaint, we've got H, history, we've got A now for assessment, and R, as I said earlier, stands for RX or treatment. Now during this portion of your narrative, you want to include any interventions that were given on scene or en route. You want to remember to document who did those procedures and when a procedure was done. You want to make sure you have a timestamp on it. You always want to include the patient's response to any intervention. You also want to have the time, dose, and route of administration for any medication that may have been given. We have, as an example here, the patient was placed on oxygen at 4 liters per minute via nasal cannula at 1533. The patient tolerated it, and his O2 sat increased to 97%. So right here, we have all of that information wrapped up. We have the drug, we have the dose, we have the route, we have a time, and we also have the patient's response to it, being his increase in his O2 sat. Now, when it comes down to trying to figure out what needs a timestamp on it, you need to have it on any advanced procedures that you do, any medications, and of course, on every set of vital signs that you have. So to look at an example of this, R standing for RX or treatment, it may say something like, en route, 324 milligrams of aspirin was given PO at 1345. 15 liters per minute of oxygen was administered via a non-rebreather mask at 1348. This brought the patient's SpO2 up to 94%. Nitro was foregone due to the patient's erectile dysfunction medication. So there's a good example of a treatment portion of your narrative. I'd like to look at a specific part of it, the very last sentence right there. Nitro was foregone due to the patient's erectile dysfunction medication. So in your treatment portion of your narrative, you want to include everything that you did to treat the patient, but you also want to include any information to let the receiving facility know why you may have varied from a standard of care or from any state protocols that you may have. So for a chest pain patient, we would be expected to, depending on your level of certification or licensure, kind of the standard would be aspirin, oxygen, nitroglycerin, and of course morphine if you're able to give morphine. Those are our MONA drugs is what we call those. So if I'm reading this person's narrative or this call's narrative, when I see that this patient's being treated for a suspected MI, I'm going to be expecting a few different kinds of treatment coming up, nitro being one of them. So if I don't give that, I need to put in here why I deviated from that standard of care or from that protocol. So that's what this last little sentence is. Nitro was foregone due to the patient's erectile dysfunction medication. This is really important to know, one, because it's going to prevent them from giving that patient nitroglycerin. Another reason being it's going to let them know, one, that it's not been given, but it's also, if you want to kind of be selfish for a moment, it's going to reflect your patient care saying, hey, I wasn't just doing a half job. I was giving high quality patient care, and through my assessment I determined that this would have been potentially dangerous for that patient. So that kind of wraps up the treatment or the R section of the chart method. Now moving on to the last portion here, T stands for transport. So now we've wrapped up chart. We've got C, chief complaint, H, history, A, assessment, R for treatment, and T for transport. During the transport portion of your narrative, you want to include where you transported the patient to and whether or not you use lights and sirens, emergency or non-emergency. You want to include any treatment that was not already included in your R portion that was done en route to the hospital. You want to document any changes that may have happened in the patient's condition. And you always want to document to whom you transferred that patient to and what their position was. For instance, if you gave report to an RN and you transferred care to an RN, you want to document who they were and the fact that you transferred care to them and of course what level they were. Okay, so we're going to look at an example of this. An example may read, the patient was transported to the ER with lights and sirens in the semi-Fowler position. The patient's condition was monitored throughout transport. The ER was notified of the patient's potential MI and the STEMI team was activated. Once at the ER, patient care was transferred to the ER/RN. No further services were needed and EMS returned to service. So this is just a very basic kind of transport. However, it does state right here or gives an example of how a form of treatment may not really fit in the R portion, but may fit better in the T portion. Really, it's just a matter of opinion, but notifying the STEMI team and notifying the receiving facility of the potential MI still is a form of treatment, because our treatment doesn't just look at what we can do for the patient right then, but also looks at what we can do in the long run. So really notifying them, giving them a heads up that this patient may be having a heart attack is really a great example of how a form of treatment can fit into the transport portion of your narrative. Well, that wraps up the chart format, but I want to look at one more thing. Many people have adopted the chart format to read D chart E. And this information was already really included in the chart format. However, it just adds a few more steps in there, brings a little bit more clarity and a little bit more direction when reporting your narrative or when following this format for your narrative. The D stands for dispatch. This is where you record any information about how you were dispatched and your response to the call. If you remember back in the example that we gave for C, I said I like to include how we were dispatched out as. So if you can remember that, then you don't have to refer to it as the D chart E method. If you can remember that dispatch fits into the chief complaint, or that introduction portion of your narrative, then you're doing pretty good. And the last part, the E, stands for any extenuating circumstances. This section is really used only when there was something that delayed transport, such as a bad wreck, bad traffic, anything else that was really unusual. This is kind of just all other things that could possibly happen during your transport, or anything that was really unusual, you can tag right there at the very end. Should something have happened, say the patient fell off the stretcher somehow, you can tack that in right there at the very end of your narrative, so that way it's still documented, but it doesn't kind of throw off your typical format. So whether you refer to it as the chart method or the D chart E method, really whatever helps you include all of this information, it's really up to you. So what you see right here is exactly what we're looking for when you submit one of your narratives. We've got the chart format, and I've taken the exact examples that we've used as we've gone throughout this lecture and put them back to back. So we want to see it C-H-A-R-T, just like this, broken down. Now, not everyone breaks it down exactly like this, but while you're getting used to writing in the chart format and while we're grading you on that, we want to see it broken down. So one, it makes it easier for us to go in and see where you might be having some issues, and two, it helps you follow the chart format and know after C what comes next, of course, and just like I said, progress through that. So I'm not going to read this, but we see here it's broken down color-coded. It's got our little sections broken off, C-H-A. We move along. We've got the continuation of A, R, T. So we've got chief complaint, history, assessment, RX or treatment, and then our transport. So this is exactly what we want to see as you submit your narrative. Now finally, to summarize, we are really pushing hard this chart format because we feel that ultimately this is going to better your patient care, because like we've said all along, your documentation is an extension of your patient care. And the chart format, the chart method, is going to help you bring consistency to your documentation. It's going to help focus your efforts and hopefully help you write better narratives. Now we're going to be reviewing and reading all of your narratives as you go throughout this program, and we are going to be comparing your narratives back to the information that's found in these 4 lectures, and your format is going to be compared to right here, the information that you can find here in lecture 2. So we're going to read through them, we're going to compare them to this. Obviously we don't expect perfection, but we feel that the chart format is easy enough to follow. If you break it up like that, C dash, and then the chief complaint part, have a little space H, and then give us your history. With that, we feel it's really easy, and you should be able to get it. If you have any questions, you have my email, you have my cell phone, shoot me a text or send me an email, and I'll be happy to explain more of these things to you. Now, if you're not able to get it right the first time, we are going to reopen your narratives. We are going to reopen your documentation in FISDAP. not to be mean, but to give you that chance to start building this habit where the chart format is what flows naturally as you move into writing your narrative. So I hope you enjoyed this information. I realize these narratives or these lectures can get a little difficult. Just hang in there, and I'll see you on lecture 3.